All right, we're going to go ahead and get started. So welcome back from your break. Welcome to this session, which is EMS Supplement Spotlights. A few little housekeeping things, which you've heard a bunch of times, but so I'm Nicole Clement from the Technical Assistance and Services Center, or TASC, and I'm a program specialist with TASC. Breakout sessions and plenary sessions are being recorded. If you have any technical difficulties, please utilize the chat feature and we will help you. Please use the chat feature if you have a question for either of our speakers. And I think that's it. So with that, I'm going to go ahead and let you know this session, State Flex Program staff from Ohio and Arizona will share their experiences and successes from the EMS Supplement Funding Project. By attending this breakout session, participants will be able to identify successes and lessons learned from 2 of the 8 Flex EMS Supplement projects, relate an example of community paramedicine implemented through the Flex program, and hear an example telehealth and EMS activity of the Flex program. These 8 projects are now wrapping up. They will be done at the end of next month for the most part. There will be information from their end of year report shared out with all of the Flex programs in some way, shape, or form. At least that is what Talia and I have kind of discussed exactly how we will go about sharing lessons learned and successes from those 8 projects, not only with you guys as state Flex programs that are interested in that information, but also how F4HP is going to use that information going forward. The 8 states are going to have a small group meeting in August, and that will be recorded and made available. So that'll be just another way that other state Flex programs and anybody that's interested in those 8 projects can learn more about how they went over the 3 years. So introducing our speakers, Jill Bullock has been with the Center for Rural Health and working on the Arizona Flex program since 2011. She has over 25 years of experience working in government and nonprofit entities in healthcare marketing and outreach to the underserved. In 2014, Jill became the Flex coordinator, supporting Arizona's 16 critical access hospitals and their 38 affiliated rural health clinics. In 2015, she was appointed the associate director of the Center for Rural Health. Daniel Prokop in June 2022, so just last month, became the Ohio State Office of Rural Health Director at the Ohio Department of Health. Prior to that, Daniel was the Ohio Flex and Ship coordinator for over 5 years. Daniel has a Master of Science in Health Systems Administration from Georgetown University and a background in quality improvement, having worked for 2 large health systems and a small medical home servicing people living with HIV and AIDS. So with that, I will go ahead and turn it over to Jill.
Okay, so share my screen. All right, can you see my screen?
Yep, can you just go into presenter mode?
Yep, working on that. Okay. Am I in presenter mode? No.
Yes, but
you're seeing the wrong screen.
Seeing the wrong presenter mode.
Okay, hold on a second.
Okay, yes, the wrong screen. You're exactly right. I know what you mean.
All right, so new share. There we go. Is that better?
Yes. Perfect.
All right, good. So, okay. Thank you, everybody. I am Jill Bullock, as Nicole alluded to, and I just want to let you know the Arizona Flex program was awarded one of the EMS supplemental grants in 2019, and that was to develop a telemedicine infrastructure that places rural EMS agencies at the cutting edge of medical care. And just wanted to let you know that we have our Expert Emergency Medicine Research Center at the University of Arizona is responsible for this project, but they weren't available today. So you get me on their behalf. And I do have the support of Joyce Hospodar here on the call, who has also been involved in this project. So what I want to do is minimize this real quick. Can you see the video? Can you see that screen?
Nope, we still see you present.
Oh, okay. Okay, so new share. Here we go. and clear sound. Okay. How about now?
Looks great.
Okay.
As a paramedic, as a firefighter, we get into this profession because we want to help people. And when you're a paramedic and a firefighter in a rural environment, you're helping people with fewer resources and more austere environment than you would in a larger city. So when we get a call for a chest pain patient, on the way, we're thinking, okay, this is an AZ ready type call. And when we get on scene, we'll start our assessment. We'll usually run a 12 lead because that's really important diagnostic information.
Hello, ma'am.
Hi.
My name's Emma. I'm a paramedic. That's Peter. He's my EMT today. What's your name?
I'm Joanne.
So why are we here, Joanne?
My chest started hurting and it got hard for me to breathe.
Yeah, okay. If it's okay with you, why don't we just get a really quick set of vitals on you and take a look at your heart and then see what we want to do from there, okay?
Okay.
All right, and I'm going to go ahead and call a doctor and kind of get their opinion too. Does that sound all right?
Yeah, anything to get feeling better.
Yeah, okay.
I'm scared because this has never happened before.
Hey, Dr. Gaither.
Hello, can you hear me okay?
Yeah, can you hear me?
Good.
Perfect, all right.
So AZ Ready, AZ-READI, is a grant-funded project that's run out of the University of Arizona Center for Rural Health. What the grant is aimed to do is to bring telemedicine services to our rural EMS communities. It really brings physician-level care to communities that might not have good access to that care. In the last 4 or 5 years, a new service has become available across the United States called FirstNet. That FirstNet service is a wireless communication service that's dedicated to first responders. With that new innovation, we thought this was a great opportunity to try out this program and see if it really did improve care for our rural communities. For the AZ Ready project, what we really focus on is providing care, for example, for patients with chest pain. Before this program, if you developed horrible, crushing chest pain, the paramedic would just call the helicopter and transport you to the hospital as quickly as possible. With this program, the paramedic can get an EKG, send that EKG to our physicians. We'll take a look at the EKG, talk with the patient, and help come up with a decision. Is this patient okay to be transported by ground, by an ambulance, or can they even go by their own vehicle, saving that individual money and allowing the paramedic to stay in the community to provide the services that community needs?
So as operations chief at Sonoyta Elgin Fire District, my job is really to oversee the day-to-day running of the department. So making sure that our crews are scheduled and they have what they need. Also responsible for the stuff around here. So making sure that our vehicles are on the road and running correctly. And then really anything else that the fire chief needs me to do to make sure that we're basically mission ready every single day. Being in a rural community, and by ambulance, we're roughly 45 to 90 minutes away from a hospital, depending on where we pick the patient up and which hospital we go to. Sonoyta Elgin Fire serves a fire district of 350 square miles. We also are responsible for ambulance transports for 725 square miles.
No stoplights. We have a Dollar General now, which makes us a little bit bigger, but before it was just a corner market store, one gas station, very spread out. Rural EMS is a whole different animal. You really have to kind of cowboy up and just do what you can with what you have. As a provider, I like it in that way because it really tests you and makes you grow, whether you like it or not. Sometimes you definitely learn from every call that you get. Spending an hour in the back of the rig with a patient, you're either really busy doing stuff or you're, having a nice conversation with them and getting to learn about them and getting to learn about their family. And at least for this hour, I'm going to get you to the hospital safely, and I'm going to kind of comfort you and make you feel a little bit better on your way there.
We're less than 15 minutes out.
Cool, thank you.
The way in which this program makes my job easier, frankly, but also more fulfilling, is that between myself and my patient and the ER physician I'm bringing this patient to, I don't have to wait until I get to the hospital to actually link all the parties together. I can do it from the point of our initial encounter with the patient. Now that we've been running the program for several months, we've entered into refresher trainings. And refresher trainings is
Okay, now I'm gonna do a new share back to this. And are you guys seeing my screen with the presentation?
Looks perfect.
Okay, good. I did it right.
Good job, Jill.
All right.
Yeah, great job.
All right. So the purpose of this was to develop a telemedicine infrastructure that helps place rural EMS agencies at the cutting edge of the medical care. So to connect the rural EMS providers with board certified emergency medicine physicians in real time, utilizing the video communication, and to demonstrate a sustainable model of rural EMS care by providing the medical direction at the time of the patient care to assist with the basic life support and advanced life support providers and the evaluation of triage in the rural communities. So the primary goal was just to get the right patient, the right destination via the right transport modality. And when it's safe to transport the patients with chest pain via the basic life support units, this leaves an advanced life support unit in the district to respond to the next call. And also when it's safe to transport patients via advanced life support ground rather than air. So then both the patient and the providers would save money. So real-time connection to the ER medicine physicians as the next thing that they needed was reliable, user-friendly telemedicine platform. So the team identified the General Devices eBridge application as the preferred telemedicine system. And after vetting several competing companies and then completing over 150 successful test calls, using eBridge as the finalist, the team moved forward with the purchase and implementation. So the key advantages of the eBridge telemedicine platform included patient data is encrypted and the application is fully HIPAA compliant. The software is intuitive, easy to install, is accessible across all operating systems, and comes with 24/7 live support. And the EMS physicians were able to provide live online medical direction with BLS and ALS providers in the live video calls made directly to the EMS physician's device. So patients' vital signs, including 12-lead EKG, were securely transmittable in real time via Bluetooth between the ZUL patient monitor on scene and the eBridge app, allowing EMS field crews to transmit this data to the emergency medicine physicians. And this provided to be invaluable part of the triage and transport decision-making process. So this is an expensive undertaking, one that is often not sustainable for small rural departments. A program such as this needs to generate some revenue in order to be sustainable. So one option currently looking into is working with other EMS agencies across Southern Arizona to become engaged with this type of project in order to create a critical mass of sorts, which might lead to one of the local urban hospitals to sponsor or pay for this type of system for our rural providers moving forward. So Banner Health is affiliated with the Arizona Emergency Medicine Research Center and is looking to expand this model at other Banner facilities. And Banner has 2 calls in Arizona. So it would behoove them to really work with more of the rural hospitals. And also part of the sustainability is our Southern Arizona Hospital Alliance, which is SAHA. And that is a group that is run by the which is run by Tucson Medical Center. And they were at our Rural Health Conference and heard this presentation and is very interested in replicating this model for Southern Arizona. SAHA is a network run by that large community hospital that works with our 4 Arizona critical access hospitals in Southern Arizona. So according to our current pre and post data, the total out of service time for EMS field units responding to chest pain calls decreased by 31 minutes. So EMS was out of service times for chest pain calls. So prior to Arizona Ready, their average was 2 hours and 2 minutes for chest pain calls. And post AZ Ready, their chest pain calls were 1 hour and 31 minutes. So during the pre-AZ Ready period spanning September 2019 through September 2020, the Sonoyta Elgin Fire Department had a total of 326 EMS calls, which excluded motor vehicle accidents with injuries. During the post-AZ Ready period between September 2020 and December 2021, there were 411 documented EMS calls, excluding the motor vehicle accidents. So of these 411 calls, 45 were dispatched as chest pain specific, and 40 of the 45 involved patients who received a 12-lead EKG on the scene. 50%, which were then interpreted by the EMS physician using the AZ Ready protocol. This resulted in the transport decision data you see here. And in general, ALS ground transports decreased by 6.6%, while the BLS transports increased by 5.4% and air medical increased by 9% overall. So barriers, lessons learned, and advice. So with a remote management strategy of project partners, as well as change of overhead at one of our participating agencies, there was some difficulty in maintaining consistent EMS provider engagement. They were able to overcome site training and education, conducting ride-alongs, and by building relationships through spending more time with the crews of each agency. Being close to the U.S.-Mexico border, language and or cultural barriers might have also played a role in this. And so it's important to show providers that we had taken the time to consider that a large percentage of the patient population in some of their areas is primarily Spanish speaking, and to provide supplementary materials that would meet the patient's language needs during the calls. And then consistent and enthusiastic EMS provider engagement proved to pose the most significant challenge throughout the course of this project. Additionally, with any new technology, rural EMS providers, as well as our board certified emergency medicine physicians, required ongoing training to remain comfortable interacting with the telehealth platform. That was where I ended the video, but the video does go on for about another 10 minutes. So especially due to a generally low call volume, which resulted in infrequent use of the telemedicine system and corresponding protocol, refreshers on interfacing proficiently with the software occurred periodically, and occasional technical assistance was needed for troubleshooting. EMS providers were asked to rely on protocol-based patient assessment guidelines to identify when the use of the online telemedicine was appropriate. Education materials were created and distributed in order to assist with this. Another issue we encountered was in working with the rural EMS agency electronic medical record system. In general, they proved to be very difficult to access due to the availability of staff in each of the fire districts, as well as the use of low-budget EMS and EPCR systems. Finally, physician availability and reliability in answering incoming telemedicine calls from EMS providers also posed a small challenge. And while we were able to create and implement a 24/7 on-call schedule for our physicians, field protocols indicated a 2-minute callback window in which the on-call physician could initiate a callback to the requesting EMS field crew. On occasion, the provider on call was not immediately available within the initial 2-minute window, and the EMS provider had to continue the call per administrative guidelines without being able to engage with the physician via telemedicine. So in some instances, this temporarily undermined the confidence we had worked to build with our EMS providers to trust that the telemedicine system would work consistently. Here's a list of our partners. Of course, it was us here at the Center for Rural Health, the Arizona Emergency Medicine Research Center, General Devices, FirstNet, AT&T, and we couldn't have done this without our Arizona telemedicine program. They helped so much with setting up the trainings and the connectivity and getting the right vendor for the project. And of course, HRSA, Federal Office of Rural Health Policy, funded the program. Sonoyta Elgin Fire Department, Rio Rico Fire Department, Banner Health, and the University Medical Center, and our Arizona Department of Health Services. So this is, and I left Joyce Hospital off the screen, off this slide, but these are our partners, the University of Arizona College of Medicine, Department of Emergency Medicine. And then you saw Dr. Gaither in the video. He was the one that was connected to the 12 lead patient. Dr. Amber Rice and Eileen Hardcastle, and she does the research. She's the research associate for the project. Myself here at the Center for Rural Health, and Joyce Hospital at the Center for Rural Health, and our contact information. So on behalf of myself and the rest of the AZ Ready team, we would like to thank you for your time today, and would like to provide some additional time for any questions or comments after Daniel goes. And I included the link to this video. It was done by our Arizona Illustrated, which is our local PBS station here in Tucson, Arizona. And it's a great video for you all to look at if you wanted to learn more about Arizona Ready. And with that, I'm going to turn it over to Daniel.
Thanks, Jill. Hi, everyone. My name is Daniel Prokop. I'm with the Ohio Department of Health. So back in 2018, I think that's when this grant writing started. One of the things we noticed was a lot of the community paramedicine white papers and information out there was urban specific. That was something that bothered us. It's less so a problem now, but it was one of the reasons why we wanted to take on this project. We really wanted to give an example specifically to other Ohio community paramedic sites that were interested setting them up in rural areas. So we wanted to give them a framework to work off of. So one of the more important things that we wanted to focus on was to make sure that it was self-sustaining. That's a really big problem with community paramedicine, is strictly finding the funding. A lot of insurances don't pay for it. I know in Ohio, Medicaid doesn't pay for it. I know some of your states hopefully do, and I hope that in the future we will, but currently very few insurance companies pay for it. So one of the things we wanted to do is to make sure that we had the right partners in place. So we've been working with the Paramedic Foundation for several years now, and they were really key subject matter experts for setting up community paramedicine. I don't personally have an EMS background. I have a hospital background. So making sure that I had subject matter experts that I could go to, specifically on setting up metrics, the metrics that the sites were going to use to make sure that they were successful and that they're tracking what they need to track. So with the Paramedic Foundation, they had this group, they worked on a work group called the Mobile Integrated Health Work Group, I believe. And they developed a series of metrics that I used when judging the effectiveness of my sites. The other thing I wanted to make sure that the EMS agencies were directly connected to a hospital, specifically, well, hopefully a critical access hospital, but not necessarily. I felt that it was a really good opportunity to make sure that the agency would be able to be self-sustaining, because even though the EMS agency might not be able to have the funding, if the hospital can see the benefit of the program with things like reduced readmissions and less ED utilization from their high utilizers, that the hospital or health system could pay for it. Ohio, every state's different, but for Ohio, the Department of Health and the Department of Public Safety are separate. So the Department of Public Safety houses EMS and law enforcement. So working closely with them was also integral for the success of my program. So given the funding of the grant, what we decided to do was to fund 3 sites per year. The same 3 sites for the 3 years, but paying them per year, $75,000 per site per year. And then that left us a little bit of extra money. So we used that extra funding to focus on EMS training. A lot of it was community paramedic focused, but not exclusively. For instance, making sure, at least for Ohio, a paramedic needs to take a paramedic refresher course every 5 years. It can be very expensive, so we chose to pay for those courses. And then we've been doing really aggressive EMS continuing education webinars since COVID. They have been very well attended, and it actually was a really great way to get or reach into these rural communities. So before the EMS webinars, we had our EMS listserv was about 100, and now it's 1,500. And that's strictly from the a combination of surveys and the webinars, but primarily the webinars. So we wanted to make sure that we picked the most appropriate sites. So we needed to make sure that they primarily served a rural area, and that there was a partnership between the hospital and EMS agency. We did give some extra points if they were county-based, and some extra points if the partnership was with a critical access hospital. So we also wanted to make sure that they were going to focus on readmissions, ambulance runs, and ED avoidances. So here are some of the deliverables that I required from the sites. And this is actually how we tied reimbursement. So we tied reimbursement to these deliverables. So we required them to submit a detailed work plan, the metrics that they plan on using, the staffing plan, the CP model breakdown, quarterly reports, and final report, which includes a sustainability plan. So one of the things we plan on doing when the program concludes in August is to publicly publish the CP model breakdowns and the final reports. That way that other sites, other rural Ohio sites, can see a peer's data and hopefully take that data to leadership and convince them that they have a good jumping off point to set up their own CP program. Sustainability. So like I said, I built in sustainability into their final report. So it was a requirement for their own programs that they figured out how to sustain it afterwards. So we actually already have one site that has set up a contract with their local hospital to be paid for each patient they refer. So that's going to be continuing after the funding for the grant ends. And the other 2 remaining sites are hospital-based, and the health system plans to continue to pay for the program out of its general revenue. So like I said, we plan on distributing the models and the sustainability plans publicly. So we have a couple different ways. We plan on blasting into the listserv. We also plan on posting it to our website and the Ohio Rural Health Association's website. A couple of the successes we had. So it was really hard to tell how much interest there was going to be. I know there's a lot of talk about CP in Ohio, but we didn't know once we put out the call for proposals, how many we would get. So we ended up having 30 people show initial interest in it, and then 18 sites actually applied for the funding. So that was a great success that it showed that there was a lot of interest. It was also really sad to only fund 3 out of 18. It would have been great if we would have been able to fund all of them. Like I said, all 3 sites expect to continue operating after the funding concludes. As far as Flex's involvement after the programming concludes, we set up these rural community paramedic quarterly calls, primarily with the sites. It was required for the sites to be on them, but we open it up to the public. So anybody who's interested in rural community paramedicine is allowed to join those calls. So we usually have about 10 people per quarter, and they basically just talk about what hurdles they've been coming up to, what successes they've had, asking each other questions about how they've addressed certain things. So it's been pretty successful way to share best practices. And it's something that doesn't really cost my office any money. It takes a little bit of the Flex coordinator's time. But so we plan on continuing those. We also plan on continuing some of the education webinars using general Flex funds. Some of the lessons learned we've had, we weren't expecting the amount of pushback from accountable care organizations. So these hospitals already had accountable care organization contracts in place. So we really had to prove that we weren't trying to poach their potential clients, patients. So that really helped things up. The other thing that held things up a lot longer than I was expecting was Irb approval. So these large health systems had their internal Irb processes. So where the independent site was able to start seeing patients within 6 months, the hospitals took almost 18 months by the time they got through Irb and their ACOs to sign off. Oops. So, and then the other thing, depending on whether you're a state agency or a university or a nonprofit, it's really important to factor in how long your own internal process is going to take. So for Ohio, we planned on taking 6 months to pick the 3 sites, and we were actually able to get it done in 5, so I was pretty happy with that. But obviously, if you're too optimistic with that time frame, it's way better to be early than for something to take a lot longer than what's expected. So here's my contact information, and I will toss it back to Nicole.
Thanks. Thank you, Daniel. Thank you, Jill. Anybody have questions for Daniel or Jill about their projects?
I have a couple of questions.
Okay, go ahead.
Nicole,
yeah.
For Daniel. On the funding that they received at the community or the EMS agencies received, the $75,000 and then 25,000 was for training, but the $75,000, what was that mainly used for?
So as far as the contract was concerned, it was to pay for the 4 quarterly reports. So we had them turn in their metrics quarterly for us. So we tied, for contractual reasons, we tied that funding to each report, they would get 1/4 of the money. But what it effectively did was it allowed them the funding they needed to set up the program and to staff it while they were still building it.
Okay. So did you have an evaluator? Like, did you contract with someone to evaluate all the data and collect all the data?
No, we had them supply the data directly to me, and then I evaluated the data.
Okay. That's all I have. Thank you.
Eva. So I see a question in the chat from Kate that Jill is addressing. Kate in Alaska, Kate Harmon asked for Arizona, how did Flex funds support the project? Jill, did you want to just unmute and kind of talk about that?
Yeah, we were one of the 8 Flex programs that received this award back in 2019. And so no Flex funds per se were used, but you had to be a Flex program to even apply for the grant. And so we were one of the 8 that received the funding.
Yes, I did not explain that very well. And I will just add a little bit more detail to that for the people that are newer from the last 6 months or a year even. There were 8 awards given to state Flex programs. Like Jill said, only Flex programs could apply for this funding. So for this 3 years, it's just been EMS supplemental funding projects that have been completely separate from their primary Flex cooperative agreement award. So completely separate pools of money that all 8 states had to do this work. So just to be clear. The other point to consider with that though is these projects that they're talking about, and really if you look at the presentation that I put a link to in the chat for all 8 projects, they could all be done with primary Flex funding. So there's not any of the projects that happen that would have to be supplement funds. You could do all of these things out of your primary Flex funding awards. Anybody have any other questions? Okay, well, the presentations are available on the attendee hub, so you can grab them with their contact information, or you can reach out to me if you want to be connected to Daniel or Jill. And that's it for today. So please utilize the instant networking feature that's found on the main page of the attendee hub. You can meet with other Flex personnel and have a bit of fun while networking. Join us tomorrow at noon Central Time. Session highlights tomorrow include a presentation from the leadership at the Federal Office of Rural Health Policy, a celebration of 25 years of the Flex program, a federal and regulatory panel discussion, and an update on the Flex program core competencies. So please check the attendee hub for links for tomorrow's content. And that's it. You all have a good night.
Thank you. You as well. See you next time.
Thanks, Kim.
Thank you.
Thanks, Eva. Have a good day.
You too.